Thanks very much, John. It's a real pleasure to be here in this beautiful setting, this fantastic meeting. I want to thank Matthew and Amy for inviting me. So I'm Philip McGuire. I'm in charge of the psychosis theme in the BRC and also the precision psychiatry cluster. And today, this is a prevention session, so I'm going to be talking about prevention of psychosis, which is actually the mental health disorder on which there's been the most work in prevention, and specifically about the possibility of using cannabidiol for prevention. So I'm sure you all know this stuff by now, but this is the cannabis plant. This is one of my colleagues, Amir Engeland, who's a cannabis researcher in a top secret plantation belonging to a pharmaceutical giant that makes cannabinoids. And the cannabis plant that he's surrounded by has two major constituents, THC and CBD. So that's tetrahydrocannabinol and cannabidiol. And they actually, if you look at the molecular structure, they're remarkably similar. But one of the key take-home messages from today's talk is that actually their psychopharmacological properties are completely different. And there was the first sort of clue to this comes from talking to cannabis users who use illicit cannabis. And illicit cannabis varies depending on who you buy it from in terms of how much CBD and THC is in the preparation. So in the old days when John and I were students, the kind of cannabis that was available had a relatively similar ratio of CBD to THC in it. But these days, if you go out in Camberwell or Peckham and try and buy cannabis, pretty much the only cannabis that's available in London has got a very high THC content and almost no CBD content. And what has been clear from talking to users is that the risk, the likelihood of becoming paranoid and anxious when you smoke cannabis is directly related to having a high THC content and a low CBD content. So this suggests that maybe CBD is doing something to modulate the effects of THC on psychosis. So about 10 years ago, we started doing experiments not with cannabis, but with pure molecular, either CBD or THC extracted from the plant, and using these as pharmacological probes in healthy people. So in these kind of studies, we would take a group of healthy people with no history of psychiatric problems or vulnerability, so just completely healthy, and then we would study them on repeated occasions, either giving them THC or CBD or a placebo, so we could compare the behavioral effects or the symptomatic effects of CBD and THC. And what this and lots of other studies have shown is that if you give anyone a big enough dose of THC, you will reproducibly produce acute, transient psychotic symptoms, so paranoia typically, whereas CBD does nothing at all. It's indistinguishable from placebo. And the other thing we found was that before you give people THC, if you pre-treat them with cannabidiol, so you give them cannabidiol about 2 or 3 hours before they have the THC, it blocks the psychotic effect of the THC. So this is a really striking finding, and it is one of the strongest pieces of early evidence that CBD might have antipsychotic properties, because it's blocking the psychotic effects of THC. This is all in healthy people. So what's the neural basis of this effect? How do these drugs, THC and CBD, act on the brain? You can study this again by taking healthy volunteers and studying them repeatedly inside the scanner. So you repeat these psychopharmacology experiments, but doing it while the subject's inside the scanner. So you can measure how their brain responds to the acute effect of the drug. And what these studies showed is that in healthy people, the two drugs act on pretty much the same parts of the brain, but in opposite directions. So remarkably, if THC is activating a region, CBD is deactivating and vice versa. And this seems to be true. I mean, this is the hippocampus, this is the striatum, but this is a general pattern that's seen across the brain. So at a neural level, in terms of regional activity, CBD and THC have pretty much opposite effects. So this really is consistent with the very different behavioral effects of these two compounds. So all of these studies made us think that CBD might be, because it blocks the psychotic effects of THC, maybe it's got antipsychotic properties of its own. And so this led to us doing small-scale, early-phase clinical trials in patients with psychotic symptoms. So This was the first placebo-controlled trial. It was done in an adjunctive design. So that means that patients with schizophrenia who are already taking an antipsychotic medication had, on top of that, either CBD or placebo for 6 weeks. So we're asking the question, if we add CBD to existing treatment, does it have an additional effect? And what we found was that after 6 weeks, the patients on CBD had lower levels of psychotic symptoms on a rating scale, and their clinicians who were blind to the treatment arm felt that they were generally, their general health was better than on placebo. And the other observation that's really important to the prevention aspect is the side effect profile. So in all the studies we've done with healthy volunteers and in this study with patients, there was no difference between the CBD side effects and those on placebo. So really remarkably side effect free. Okay, so what about prevention of psychosis? So this is a cartoon showing the natural history of psychosis in terms of symptoms or disability. So the classical psychosis classically begins at the first episode when people are about 25. But over the last 20 years, it's become increasingly clear that before that point when symptoms are clinically obvious, there's a high risk phase when there are more subtle psychotic symptoms and a functional decline. And that's called the clinical high risk state. So this is classically in the early 20s, the same age as the people that Ulrika was talking about. So it's typically student age. And if you examine the natural history of this group, they have a very different set of clinical outcomes. So about 1 in 4 people who have this clinical syndrome will develop psychosis within 2 years. So very, very quickly, they will develop a first episode of psychosis. But the remaining subjects will not develop psychosis. So being in this high-risk state does not inevitably lead to psychosis, but it's associated with a really dramatically increased risk of developing the disorder. And the other intriguing thing about this risk is that there is a window of risk. So after 2 years, the risk reverts back to normal. So if there seems to be a window of about 24 months when if you're going to develop psychosis, it will happen in that window. And this is very relevant when we're thinking about preventative treatments, because if we were going to try and prevent psychosis, we would want to cover that 2-year risk window. So as I mentioned at the start, this in terms of prevention and mental health, this is actually the most researched disorder, psychosis. So this has been going on for about 20 years, and there's been a series of clinical trials looking at antipsychotic medication or cognitive behavior therapy or fish oil. And although these trials had some initially promising results, they were generally quite small. They were usually quite brief, so usually less than 6 months. And when Kathy Davis, she's in the audience today, did a meta-analysis of the 16 trials in the literature to date, there was really no significant effect of any of the treatments. So at the moment, there is no licensed, proven treatment for preventing psychosis. And so there's a real unmet clinical need in terms of finding something that would be useful. So that's why we're particularly interested in cannabidiol. So we've done a small phase 2 trial of cannabidiol, which is combined with an experimental medicine study, where we examined the effect, first of all, of the cannabidiol on brain function. And what we found was, compared to placebo, cannabidiol seemed to target the parts of the brain that we know from independent research on the clinical high-risk state are critical to the onset of psychosis. So from our naturalistic studies in high-risk subjects, we know that this triad of areas seem to be absolutely critical to the onset of psychosis in the absence of treatment. And what we found in the cannabidiol study was that it seemed to target the striatum and the hippocampus, 2 of the critical areas in this pathway. So this is very encouraging in terms of it seems to be modulating function in the parts of the brain that seem to be most important to transition to psychosis. And then we treated people for 3 weeks to just look at the safety and the initial efficacy of the drug and compared that with placebo. So clinical high-risk subjects were randomized to either placebo or CBD. And what we found at the end of the 3 weeks was that the symptom levels in the high-risk subjects, their levels of psychotic symptoms had improved, and again, critically, there were no significant side effects. And the side effect profile is very, very important in this high-risk group, because if you're trying to prevent something in people who don't yet have the disorder and may never develop the disorder, having an intervention that's harmless is absolutely essential. So CBD seems to be quite good from that perspective. So the next stage is to try and confirm that CBD is actually useful as a potential new medicine. So the trials that have been done so far have been in phase 2 type trials, quite small. We've now got funding to do a global multi-center trial with about 500 clinical high-risk subjects. And critically, in distinction to previous trials, rather than treating people for a few weeks or a few months, we're going to treat for a full 2 years. So the rationale is that we want to give people cannabidiol to cover the risk window of 2 years. And that's, from a theoretical point of view, the best way of providing a preventative treatment. So this involves about 25 centres in the EU and North America, and we'll start in the first quarter of next year. And then more generally, aside from prevention, the other exciting thing about cannabidiol is that in relation to psychosis more broadly, we haven't had a new class of pharmacological treatment since the 1950s. So at present, all effective medications for psychosis act in the same way, which is on dopamine D2 receptors. And there haven't been any new classes of treatment since chlorpromazine was developed in 1952. So for 60 years, we've been treating people with basically the same kind of treatment. The exciting thing about cannabidiol is it doesn't act on D2 receptors as a completely distinct mechanism of action. And so if it really works, it will represent a new class of treatment and a new therapeutic target. So that's very important for the field of psychosis more generally. So the BRC at the Maudsley comprises the largest collection of cannabis and cannabinoid researchers in the world by some margin, probably 2 or 3 times bigger than anywhere else. This is just a subset of that critical mass, but these are the people who played a vital role in the studies that I've presented today. So I just want to acknowledge their contribution, and thanks very much for your attention. Thank you.